Good morning. I'm Dr. Nidhi Gupta, Professor and Head, Department of Pediatric and Preventive Dentistry. Today, I'll take a lecture on dental caries. What is dental caries? Dental caries is defined as an irreversible microbial disease of a calcified tissue of a teeth characterized by demineralization of the inorganic portion and destruction of the organic substance of the tooth, which often leads to cavitation. As defined by AAPD in 2014, ECC is defined as presence of one or more decayed, cavitated or non-cavitated lesion, missing due to caries or filled tooth surface in any primary tooth in a child under the age of 6 years. Rampant caries, it is defined as a sudden appearing, widespread, rapidly burrowing type of caries resulting in early involvement of pulp and affecting those teeth usually which are immune to decay. Now coming over to the classification of caries, caries can be classified as per the occurrence, incipient, recurrent, residual, as per the speed, acute and chronic, as per the location, pit and fissure, smooth surface caries, root caries, as per the direction, forward caries, downward caries, as per the age, early childhood caries, adolescent caries and Silene caries. Another classification given by G.V. Black in 1896, which is widely used classification. It is class 1, caries affecting the pit and fissures on the occlusal third of the molars and premolars, occlusal 2/3 of the molars and premolars, and the lingual part of the anterior teeth. Class 2, caries affecting proximal surface of the molars and premolars. Class 3, caries affecting proximal surface of the central incisors, lateral incisors and the cuspids without involving the incisal angle. Class 4, caries affecting the proximal surface involving the incisal angle of the interior teeth. And class 5, caries affecting gingival 1/3 of the facial or the lingual surface of the anterior or the posterior teeth. A class 6, which was added by W.J. Simon, was it involves the caries involving the cuspal tips of the molars, premolars and the cuspids. Then the newer classification, which was also known as ICDAS classification, with that the full form is International Caries Detection and Assessment System. In this, we do the classification as per the score, that is 0, no or slightly change in the enamel translucency with no, prolonged drying. 1, first visual change in the enamel. 2, disrupt visual change in the enamel. 3, localized enamel breakage in opaque or discolored enamel. 4, underlying dark shadow from dentine. 5, distinct cavity with visual dentine. And 6, extensive destructive cavity with visual dentine. Then is ECC classification. ECC was given by Wins in 1999. He classified it as type 1, type 2 and type 3. Type 1 is mild to moderate, type 2 is moderate to severe and type 3 is severe. What is type 1? Type 1, it involves the molars and the incisors, usually seen at the age of 2 to 5 years. The cause is the combination of cariogenic, semi-solid or solid food and lack of oral hygiene. And number of teeth affected usually increase as cariogenic challenges persist. Type 2 ECC, that is moderate to severe, that is labiolingual lesion affecting the maxillary incisors with or without molars depending on the age. Then seen after the eruption of the first tooth, unaffected mandibular incisors, inappropriate use because of the inappropriate use of feeding bottles, at will breastfeeding and combination of birth, and poor oral hygiene unless controlled may proceed to advanced stage. What is the advanced stage? Also known as the severe stage, involving almost all teeth including the mandibular incisors, usually seen in 3 to 5 years of age. Cause combination of factors: poor oral hygiene, and it is usually rampant in nature. Then what are the epidemiological of caries? The lowest, that is 0.5 to 1.7 DMF, it is usually in the Asian and the African countries, and highest DMF, that is 12 to 18, is usually seen in America and Western countries. The key factors, which are the etiological factors causing caries, are, which was given by Physiscoff in 2008, is the tooth, which is the host, then is the microorganisms, then are the substrates, and the saliva and the time. The main microorganism causing caries is Streptococcus mutans and also Lactobacilli. Then the second factor is the diet. The main is the carbohydrate diet, where that is disaccharides, which cause caries. The substrate, that is the milk, human milk, fruit juice or the sweet liquids, sweet syrup, specifiers, chocolates, soda pops and powered drink. The host, which is the tooth, which is the main which is main affected by the microorganism. It leads to hypomineralization and hyperplasia. Surface enamel more resistant to caries than subsurface caries. Then caries contains less carbonates, less water and more microorganism material. Then is the time factor. This is also a very important factor, as it leads to high risk of caries. It decreases the salivary flow and the swallowing reflex decreases, which provides more time for the accumulation of carbohydrates in the food, which is affected by the microorganism which produce acids leading to caries. What are the other risk factors? Dental plaque, mutant streptococci, tooth brushing, salivary factor, sugar, human milk and fluoride. The other risk factors, secondary risk factors, are the immunological factors, tooth maturation and defect, race and ethnicity, assets and socioeconomic status, dental knowledge and stress. Now coming over to the management of dental caries, it is divided into primary, secondary and tertiary. The main is the management of the existing emergency. Then is the arrest and control of the caries process, institution of preventive procedures and restoration and rehabilitation. Primary prevention, it begins with the initiation of the disease, timely delivery of the educational information and preventive therapies. Secondary prevention, progression of caries prior to the cavitation stage. Early detection of the incipient caries is a key preventer of the cavitation. Then tertiary prevention is by both non-invasive and invasive preventive management for cavitated lesions, conservation caries, removal and tooth restoration, and use of atraumatic caries removal and restoration with glass ionomer cements. The management, it may be affecting by the extent of the caries lesion, age of the patient and the behavioral problems. The treatment is divided into 3 visits. Visit 1, in which all the lesions should be excavated and restored. Indirect pulp capping or pulp therapy procedures. Abscess, if present, treated by drainage. X-rays to assess condition of the succedaneous tooth. Collection of saliva to determine the salivary flow and the viscosity. Fluoride application and Pitt and Fisher sealant application. The commonly used materials are the glass ionomer cement, resin modified glass ionomer cement, composite and stainless steel crown. The glass ionomer cement, the advantage, it has an adhesive aesthetics and fluoride release. The disadvantages, it is little brittle and suspect of erosion and wear. Then resin modified glass ionomer, it has an adhesive aesthetics, command set, simple to handle and fluoride release. The disadvantage, water absorption and significant wear. Composite, the advantage is adhesive aesthetics, reasonable wear property, and disadvantage, technique sensitive and rubber dam required, which is expensive. The stainless steel crown, they are durable, protect and support the remaining tooth structure. The disadvantage, extensive tooth preparation and patient cooperation is required, and it is unaesthetic. Then we come over to parent counseling. This is a very important factor which can help us in preventing caries. It should be adequate. It should be questioned about the child's feeding habit, asked to wean the child from the bottle and pacifier while in the bed. In case of emotional dependency on the bottle, use plain or fluoridated water. Should be instructed to clean the child's teeth after every feed. Should be advised to maintain the diet record of a child for 1 week, which is also known as diet diary. Then the food sugar substitution. Sugar is the main diet contribution to the disease. The importance of diet in the development of caries was suspected as and established in modern times. Sucrose is the most common sugar added to the beverages and food products, with the consumption in the developing countries, which is reported to be 40 to 60 kilogram per person per year. Other foods sugar substrates are the aspartame, sucrose, sorbitol, xylitol, etc. Then in the second visit, it should be scheduled after 1 week after the first visit. Analysis of the diet chart and explanation of the disease process of the child's teeth. Isolate the sugar factors from the diet chart and control sugar exposure. Reassess the restoration and redo if needed. Caries activity tests to be done on monthly intervals to monitor the success of treatment. Then in the treatment third visit, grossly decayed teeth which require endodontic treatment are followed by the crown. Unrestorable teeth should be extracted and followed by a space maintainer, and the patient should be revisited and recalled after 3 months. There are few IAPD guidelines about ECC in 2020. They categorize it as low risk, moderate and high risk. At low risk, that is the child has no caries, no new lesion in 1 year, no white spot lesion, and high socio-economic status. The preventive therapies do work in this, in which brushing with the fluoridated toothpaste twice a day and application of sealants. Then is the moderate risk, in which the child has one or more lesions, one or more than in 1 year, frequent white spot lesions, and moderate socio-economic status. The preventive therapy can be brushing and with fluoridated toothpaste twice a day, professional application of fluorides at 6 months interval, and application of sealants. Then is the high risk. In this, children have one or more proximal lesions, more than 2 lesions per year, numerous white spot lesions, low socioeconomic status, mother has active caries, appliances in mouth, and high frequency of sugar consumption. The preventive therapy, brushing with fluoridated toothpaste twice daily, systemic fluoride supplements, professional applications of fluoride in every 3 months, brushing with high potency of fluoride that above 6 years of age, and application of sealants. The recommended caries management protocol for 1 to 2 years child that is low risk is recall after 6 to 12 months. Twice daily brushing with 1000 to 1500 ppm of fluoridated toothpaste. Diet counseling is required, and periodic monitoring of signs and caries progression. Then moderate risk, recall after 6 months. twice daily brushing with 1000 to 1500 ppm of fluoridated toothpaste, and professional topical fluoride application 6 months. Diet counseling is required, and careful monitoring of caries progression of incipient lesions and preventive programs. Then is the high risk, which patient can be recalled after 3 months, twice brushing daily with 1500 ppm fluoridated toothpaste, professional topical fluoride application every 3 months. Diet counseling helps in it, and careful monitoring of the caries progression of the incipient lesion. Then is the low risk patients for the age 3 to 5 years, recall after 6 to 12 months, radiographic evaluation after 12 to 24 months. Fluoride application, like twice brushing with 1000 to 1500 ppm fluoridated toothpaste. Diet counseling works in it, and periodic monitoring of the signs and care of progression of caries. Then is the moderate risk, that recall after every 6 months, radiographs every 6 to 12 months. Then the fluoride application and brushing twice daily with 1000 to 1500 ppm toothpaste. Diet counseling and careful monitoring of the caries progression of the incipient lesion, and restoration of the cavitated lesions. Then is the high risk, recall after every 3 months, radiographic evaluation every 6 months, fluoride application and twice brushing with fluoridated toothpaste. Diet counseling, then careful monitoring of the caries progression and restoration of the cavitated lesions. Now coming over to the difference between nursing caries and the rampant caries. As per the age, it is specific form of rampant caries, and infants and toddlers are affected. Rampant caries is an acute widespread caries with early pulpal involvement of the teeth, which are usually immune to decay. It is usually seen in the age group of and adolescence. Then dentition involved in nursing caries is the primary dentition, whereas in rampant caries it is primary and permanent. Then the clinical features, specific form of involvement, that is the maxillary incisors followed by the molars, and the mandibular incisors, they are immune to decay. Whereas in rampant caries, surface considering immune to decay, like that is the mandibular incisors, are also affected, and it rapid appearance of a new lesion takes place. Then what are the etiological factors of nursing caries? Improper feeding practice, that is bottle feeding, pacifiers used dipped in honey, and prolonged breastfeeding. Rampant caries, multiple factors which cause caries, that is the diet, the decreased salivary flow, frequent snacking, etc. The treatment, if detected early for the nursing caries, it can be managed by topical fluoride application and education, and direct towards maintenance of the teeth. Rampant caries, pulp therapies in extensive cases, and long-term treatment if permanent teeth are also involved. The preventive for the nursing caries, education and prevention, and in rampant caries, dental health education at a mass level involving people of all ages. The recommendation, active caries lesion should be tempered with glass ionomer cement to control caries progression. For children with high risk or multiple surfaces, the use of stainless steel crowns. No complaint children with SS crowns should be managed with comprehensive treatments under general anesthesia. The AAPD preventive guidelines, infants should be put to sleep, should not be put to bottle sleep. Wearing of bottle should be done 12 to 24 months of age. Parents should be encouraged to drink infants by the cup. Consumption of juices by the cup. Oral hygiene measures should be implemented by time of eruption of the first primary tooth, and oral health consultation every 6 months of the eruption of the first tooth is recommended to educate parents and to provide guidance for the prevention. Thank you.